afternoon, everybody. It's hard to be after lunch, but we hope that we can, with our session, Last Mile Health, Helpful Tech for Rural Areas, give you some energy. My name is Nikolaus Schumacher. I'm the moderator for this afternoon session. And when I'm not moderating, I'm the CEO of Nambaya. And Nambaya is one of the new healthcare startups which is providing services not only for rural areas, for patients and all of this. With me in this afternoon session are on stage four persons which I'd like to introduce. First will be Lukas Dölger, University Medical Center Schleswig-Holstein. Next one, Dr. Peter Fröse from the Pharmacists Association from Schleswig-Holstein. Somebody from you mentioned it, be interested that a pharmacist sits here on the panel. Then we have on the opposite side Professor Steffen Hamm from the Ostbayerische Technische Hochschule in Weiden. And in the middle, Dr. Hesser from Merck is there responsible for the very nice international project where he will give us some insights, Kurafa in Kenya. We have organized this session, small welcome, then quick introduction, and each of the participants will introduce themselves and what they are doing or what they are planning, especially for activities with tech in rural areas. And then we hope we'll have a good discussion with questions from your side about the lessons learned. Here you see that is a picture coming up from some of these small devices where you can make or measure online via Bluetooth cardiac patients. It's already developed. It's coming from a Finnish company, and here in the neighborhood is a booth from a Finnish from Finland where you can see some of these innovative products. We, as Nambaya, is a company which is active in Germany, but in South Africa too. And in the South African market, we introduce these services to the state business and will start next year in rural areas. But it's easy. You can use this device and a normal Android mobile device and the app, and your doctor have a dashboard and compute on the computer and get an alarm when he sees some irritations or some cardiac problems in the measurement. So to give you a little bit of flavor. But now I'd like to hand over to Lukas Dölger. Lukas Dölger, what I learned before, is studied e-health. And for me, it's always surprising as a medical doctor, more coming out of this traditional way. So how our education system is changing and is building in these requirements in such kind of education. And Lukas, please give us a quick introduction, where you are coming from and what is your project, and we are happy to have you here.
Thank you, Mr. Schumacher. So my name is Lukas Dölger. I'm from the University Hospital in Schleswig-Holstein and the Institute of Emergency Medicine, and I work as a project coordinator there for telemedicine issues. Our current project is called Halligemed. That's a word combination out of the German word Hallig, which is a remote island in the North Sea with some special circumstances, and the E-Med for electronic medicine. So we do a telemedicine project from our hospital in Kiel to these remote islands in the North Sea. We have the situation there that these remote islands are flooded completely in a year by 4 to 6 times a year, and there are only like small hills on that with houses that are no longer connected to each other. So there is no possibility to do any patient transport to other houses or hills or even to onshore. It's very hard for the emergency helicopter or even the emergency ships to land there, to get to these islands and to do the patient transport and bring them to our hospital. On these islands, we start on 2 of them with the biggest number of inhabitants. There are only about 100 inhabitants per island, but in a sum we have 120,000 tourists per year, and that's such a big number we want to work with. There is on each island one caretaker who's responsible for all these inhabitants and for the tourists too, not only for emergency cases but also for the classical ambulant care. He is responsible and liable for all these patients, and there is no doctor, so no emergency doctor supply in any cases of emergency, and that's the big problem we have there. And that's the main reason why we funded this project, telemedicine project Halligemed. The main issue will be to have a connection between these remote islands and our hospital via telemedicine. So what do? We bring some new devices to these islands, like you know from the classical rescue services. They are like monitors which can measure the vital data of the patient. So something like blood pressure and 12-lead ECG and heart frequency and blood oxygen and so on are measured at these islands by the caretaker and send it live via this device and the mobile data to our hospital, where in the new telemedicine central a doctor can work with this data and can give now any treatment, any medical devices and advice to this caretaker, so he can get virtual to these islands unless there is no really present doctor on these islands. And that's what we start in December this year. So we had the planning phase from April on, and we'll start the building up of the telemedicine central from December on this year.
Okay, thank you, Lukas. Who is sponsoring the project, and how is it in the case of reimbursed? Is there a case who will reimburse, who will pay for it?
So, good question. We are funded by two ministries on a federal base. There's the social ministry and the interior ministry that's also responsible for the rural areas. That's, I think, a big point for other projects. They are funded too by a federal base or by state base and ministries and agencies. And yeah, we have two other ways to be funded to the from the insurances or even from programs like Interreg or Innovation Fund in Germany. But that's not how we get to the end of the project.
Okay, thank you. We will come back later.
Yeah.
So the structure in our session is that we're going from the north to the south. The next on the north is Dr. Peter Fröse. He is a pharmacist, a real pharmacist. He is the president of the Pharmacist Association in Schleswig-Holstein, and he's one of the speakers for digital of the ABDA. And he's one of the most innovative pharmacists which I met. And Peter, do you like to flip you here through this short presentation and give you an update what you are planning?
Okay. At first, it's a little unusual. My profession is a little underrepresented in this area. I'm feeling some lonely. I'm just the only pharmacist. And you may ask, why is a pharmacist sitting here? What has a pharmacist to do with digital health and something else? At first, in northern Germany, we have a big tradition of working integrated. Since 40 years ago, we are talking constantly with our doctors. We are doing our political business together. And so I have no problem to give you the best wishes from the head of the medical doctors in northern Germany, Frau Schliffke, which I've talked to just last week. So, integrated digital health is our concern. And what has a pharmacy to do with this? What is the obstacle of a pharmacy in this area? So, a pharmacist is also a healthcare professional, and he's very easy to reach. So, if a patient needs digital assisted healthcare, it's a good idea to think about to introduce the patient just in the area of the pharmacy. And we are just trying out this. Our focus is a very, very specialized one. We are focused on drug safety. Especially, we are focused on drug interactions. And if you take a closer look at drug interactions, you may notice that drug interactions are detected easily by comparing databases, but that doesn't say any word about it if it's a true interaction which happened at the patient. And a good example is the QT time prolongation, which occurs if you take some medications together. Something like haloperidol or something else. If it's taken together with other drugs, this complication leads to tozadipin entities, and they are very expensive, and they are very impressive in a few words for the patient. They lead to maximum costs at the area of my colleague at the right. So it's our goal to test out a new way to detect these interactions, these true interactions, when they happen. What we're doing there is to negotiate on the one hand with the doctors, of course, and with the statutory health insurance, which is interested, of course, because the resulting costs in the area of the clinical treatment are massive. So we are joining together with Dr. Schumacher, and we would like to place the devices pharmacy assisted. That's only our role. We are assisting, and to make sure that these data to make sure that these data are transported to a so-called navigation server. This navigation server contains the ECG data, in which we, as a pharmacist, we don't look at this. That's not our obstacle. That's not our task. But we service the patients. We engage the patients to use this way to keep to track their own health. And medical doctors will look at these ECG results, will identify patients in which this QT time prolongation really exists, and will inform them immediately. So we hopefully will find out patients and make sure that they get the right treatment on the right time. This is true Arzneimitteltherapie-Sicherheit, pharmaceutical security activation, because it's happening in real time and in lifetime. So we are very happy that we can help to introduce this system, and we are trying out this in northern Germany. A little thing in the addition, I've spent half a year on one of these hallix, and I know how it is to live there, and I'm very lucky that there are possibilities to do this. Just 2 words additionally, what other projects are running on the side of the doctors. Another project is running, which is called the Telemedizin Rucksack, the backpack, telemedicine backpack, where telemedical devices are brought to the patients in rural areas by nurses or somebody else. That's worked out at the Kassenärztliche Vereinigung, and there's another project running. And just recently we focused on the other rural areas that we have in Germany, that are the so-called social rural areas. If you look at the parts of a city where the houses are high and the incomes are low, then you should mention that there are true problems in getting health care just where the people need them. They have no money, they can't travel long distances, and they need health care at this point. And we see that pharmacies and medical doctors are going out of these areas because these areas are very, very intense, need very, very intense medical care on the one hand, and you don't have the chance to refinance many things in the case, especially of the doctors. So that's another problem which we hopefully get telemedical Unterstützung, support anyway. Thank you.
Okay, thank you, Peter. The next will be not Boris because he's the most southern project. So the next will be to get a little bit the balance between North Germany and South Germany from Bavaria, Professor Hamm. And he is coming from the Ostbayerische Technische Hochschule. For me, it was new. Yeah, and we were happy to have you here, and we'll be interested what you can tell us about your projects and your experience.
Yeah, thanks, Mr. Schumacher, first of all, for inviting me and for having me here on the panel. As you already mentioned, I'm professor for healthcare management and healthcare economics at the Ostbayerische, so the East Bavarian Technical University for Applied Sciences. The advantage of our Ostbayerische Technische Hochschule is we are definitely located in a region that is the topic of the panel today. So the northeast of Bavaria is a very rural area, and if we want or not, we have to challenge, or we have to face the challenges there in the field of healthcare, in the field of rural healthcare. Of course, we all know that in the rural areas we have the challenges to face, which everybody has to face in the healthcare system: demographic change, medtech progress, and so on. But as you also know, there are additional challenges. For example, when it comes to healthcare logistics, to patient logistics, to accessibility of healthcare, and so on. So this is also actually our motivation why we decided to put a focus on this field of rural healthcare at our University of Applied Sciences. I don't want to talk about actually about a concrete project, but rather about the structures that we derived from these challenges, and about topics where we have placed different projects. First of all, regarding the structures, what have we done there, or what are we actually right now doing there? Our observation is, or was, that actually healthcare is a very interdisciplinary topic. So if it comes to the treatment of the patients, there are so many different parties and players involved: medical doctors, pharmacists, medtech companies, and so on. But if you look at projects in this field of healthcare, funding projects and other projects, then it tends to be a rather silo approach. So in many cases we have data silos, we have silos where just two parties work together, and so on. And this is actually, this actually triggered us to embark on a so-called competence center for rural healthcare. This is not a building, although we know that politicians like buildings because they can open up the buildings in very impressive ceremonies, but that's not our intention. Our intention is to create a center for rural healthcare, to bring all the players on the table, to bring all the players together. The players, of course, from science, this is our contribution, the players from the healthcare industry, the players from the healthcare providers, and of course also local politicians that are involved in the care system, and last but not least, one party that is slightly forgotten sometimes in the healthcare system: the patient. So all these players are involved in our Center for Rural Healthcare, and what we do there is actually, if there is a new project in the region, then every project has to go over this Center for Rural Healthcare to just improve the coordination of the projects and of the activities. So as I already mentioned, in the field of science, of research, it's our duty, it's our task from the Ostbayerische Technische Hochschule. Then for the field of healthcare industry, we have opened up a branch of the National Cluster of Excellence for MedTech and Pharma, the so-called Medical Valley, which is also located in North Bavaria. And now, most recently, we have opened up a branch in Weiden, where our University for Applied Sciences is located. Then there's another field for the healthcare providers. In Bavaria, there is a program maybe one of you has already heard about it, the so-called Gesundheitsregionen Plus. The idea of these regions or of these programs is to bring together the healthcare providers, also to embark on joint projects, and of course the fourth pillar, as I already mentioned, is the local policy. So under the umbrella of this Center for Rural Healthcare, we all have committed on a joint strategy to jointly work on more efficiency and more effectivity in this field of rural healthcare in our region. So players from the region for the region, not this typical top-down approach that we all know in the healthcare system. This is the structure that we are right now building up, and to give you just some insights regarding concrete projects, topics, where are we working on. I've already mentioned it. Rural healthcare means normal challenges and additional challenges. So one of the biggest challenges is the topic of healthcare and logistics in our eyes. So optimizing existing processes, existing patient processes, existing processes of delivery in the healthcare system. This is one big field we are working on. And of course, not only the process approach, there's also a rather structural and an organizational approach that we are working on. What are the topics we're dealing with there? Well, just ask yourself the question, if the normal hospital that you all know, hospitals in rural areas, one of the main topics, is the normal hospital that you're all acquainted to, will it look like the same in 10 or 20 years? So when we talk about closing down hospitals, this does not necessarily mean in our eyes that we have to close down healthcare provision. So restructuring and building up new models of healthcare in these regions is also one of the big fields that we are working on.
Okay, thank you. Who is financing these rural healthcare center?
Well, as I mentioned, it's actually just a collaboration of existing activities and existing parties. So best of all, it's actually there are no additional costs.
Okay, on top, and it's coming from the Bavarian government.
Yeah, of course, something like this Gesundheitsregionen Plus. They are founded by the Bavarian Ministry of Health, and then of course projects that we all have already at our university. So there's no additional no additional finance necessary.
Okay. Later in the discussion, perhaps we'll be interested how you can roll it out, and how it becomes to the so-called Regelversorgung, So what will be the other hurdles?
Good question.
So now we come really to the south, to Kenya. Dr. Boris Hesser is coming from Merck, and he's running Merck's very nice project, Curafa. Please, Boris.
Yeah, thanks, Nick, for the invitation. Yeah, so I work for Merck in the global franchise for endocrinology and general medicine, and we have launched about 2 years ago an initiative called Curafa to provide primary healthcare access to the underserved population in Kenya. Reason for that is Merck is a global operating company, and it has indeed strong businesses in emerging markets, and we are well aware about the challenging situation globally that half of the world's population basically has no access to essential healthcare services they need. So for us, this is kind of a pilot initiative to see how can we, in a sustainable way, provide primary healthcare services to the underserved population. So as I said, we termed this Curafa. It's just a synthetic word out of cure, and Afia. Afia is Swahili for health, and cure, you all know, it's like healing. And the idea was to actually set up points of integrated primary healthcare services. We started this initiative based on an original corporate social responsibility project in Ghana, where Merck donated to pharmacists from Ghana, basically a container pharmacy. And this initiative was very, I think, well intended, but the reality is if you do CSR initiatives, they usually have a limited lifetime. So the idea was, can we develop out of that more comprehensive model that also is eventually sustainable? So when we analyze the situation, and this is to your left on the left right up corner, this donut model, it's basically after the analysis of the healthcare system in various countries settled on Kenya, given also the technologically advanced state there. To provide a comprehensive model that provides access to medicines. Important to say, this is not a Merck pharmacy. This is indeed a normal pharmacy where the entrepreneur is fully in charge of the stock. It's really more about the model to provide primary healthcare. It's not about the model to sell Merck medicines here. So you will have prescription drugs, over-the-counter drugs, digital health solutions. We try to work with insurers that also treatment can be financed or medical treatment financially supported or insured. Then thought about a certain facility experience for the low-income population. That means you can have wireless access there. You can charge your cell phone. You can have education through 2 TV screens. And the nurse and the pharmacist, who are the end entrepreneurs in that facility, will be supported by tablet computers and digital health applications. And at the end, all that should be then supported by medical education and integrated in the local healthcare ecosystem. So far, you see on the left bottom a little model of this facility. It's basically a 3 by 10 meter facility, which has the critical minimal, if you want, the minimal viable product for a healthcare unit. And we set them up all in the outskirts of Nairobi, about an hour of Nairobi, and concluded, let's say, the setup just in this month. So next year is all in focus of integrating, that means connecting to the local healthcare system. So we developed a patient management platform and work with third parties that are also present here at Medica to provide relevant digital health solutions, especially for screening patients on relevant, on critical diseases in that area. So more emphasis just that it's not Merck employees. This is indeed an initiative that also promotes entrepreneurship of local pharmacists and nurses. So this is a little bit an overview, and I think in the context of rural healthcare and where pharmacies can go, maybe a beautiful exemplary model that is here maybe relevant for the discussion. So thank you, Nick.
Thank you, Boris. Was it difficult to find a qualified person to run these shops or these point of care, the facilities?
So it was actually interesting. So first of all, yes, there's indeed a huge shortage on healthcare professional. We did not have an issue of getting CVs. However, most of the time people then want to be employees by Merck. And I think it's more the question of not finding the person, but finding the entrepreneur spirit who is willing to take a chance. But we are very successful in doing that. So we have all our nurses and pharmaceutical technologists, maybe also important. It's a cadre below a pharmacist, because only they accept also the income levels in low-income environments, recruited for our initiatives, yes.
Okay, thank you. Are here some questions to the panelists?
So I'm basically doing my PhD thesis and trying to compare the healthcare system in Europe and in China, and to also compare the rural and urban settings of healthcare systems. So in your opinion, what is the large difference between healthcare system in rural and urban areas? And what will IoT change in rural areas, for example, to easily provide access to order medication online or teleconferencing with doctors you need? Is there any already initiatives doing that? And also to you, what is the ECG sensor doing in the pharmacy? Isn't it used to monitor, like, I don't know, what kind of indexes are you talking about?
Peter, you're starting? Yep.
For the second question, it's a 2-channel ECG, and we are measuring an ECG over 24 hours, and we're taking a look for QT time prolongation, which is a sign for critical interaction between these two, or some drugs which are prescribed or which can be bought by patients via OTC. So that's the group of patients which we want to monitor, and the solution, the digital solution in this kind is that we transfer the data to medical doctors or specialized clinicians which analyze and do also the primary communication between the doctor and the patients. That's due to legal restrictions. Pharmacists can't do a diagnosis. This has to be done by a medical doctor. The first question is a very interesting one, because I think if you're thinking about how to organize healthcare in rural areas, the first thing everybody thought about is to directly give the patient access to digital healthcare. But there are a lot of studies which show if the digital healthcare is delivered to the patient by a professional. This may be a medical doctor, or this may be a pharmacist too, which is also a white kid. And it's much more effective. And I think it's a very interesting way to do the integration. You can do the integration on the side looking for how to give medical treatment by doctors into the rural areas. Or you can look, is there a business model which works, that is pharmacy, and give an addition with medical services. So you have 2 points filled. The first is you have a running business model which is stable, and the second one, and which is more important, is you give the patients in the rural areas access via a trained healthcare professional. The trained healthcare professional isn't a doctor, but he needs to be a doctor. This is stated out, it's a nurse or a trained pharmacist. That's okay, because they must be trained to identify the level of interaction which has to be taken by a qualified medical doctor or a clinician also on. So you can combine these two strains, especially because there's a running business case. It's extremely difficult to build up business cases despite of this.
Maybe I can add something. I totally agree with you, and this raises actually the question: are there the necessary role models already existing in our healthcare system, and is there actually a need perhaps for new professions? We are discussing right now this new profession of the physician assistant, for example, which can exactly be seen between the doctor and the nurses, for example. And in my eyes, we have to think in a broader horizon to cope with the situation in rural areas, because especially from health policy, in my eyes, we still ask the wrong questions. We still ask the main question, or the two main questions are: how can we guarantee our normal hospital as we know it, and how can we bring young doctors to rural areas? So in this case, I always like to compare it with a very famous quote from Henry Ford. I guess you all know it. He said, if I'd asked my customers what do they want, they would have said faster horses. And that's exactly the point. He did not ask for a car, but he asked for a new solution in mobility. And we are asking how to bring doctors to the areas, but actually our question is different. Our question is how to guarantee high quality care wherever you are, in rural areas or in urban areas.
And one more comment, because the lady asked for China and what is a challenge, for example, in Kenya, and what we see also when we looked at different emerging economies, where healthcare services are definitely underserved, healthcare needs are underserved. Actually, it's the health-seeking behavior of the population which is a big issue. That means you may have a health post there, but the patients don't come because they don't know they are sick. So how do you get this level of education and health-seeking behavior up? It's a huge issue, and that cannot be done by a nurse, by a pharmacist. That's basically almost like an infrastructural problem. So that's definitely a challenge, and it needs time. So when we now set up the health post, we also work with bigger NGOs that actually work with community health workers to engage the entire community and make them aware that people should maybe check their blood pressure, they should check their sugar, and so on. So that's a big challenge.
Okay, thank you. Some comments from your side, but I guess.
So when we talk about how we should bring new technologies in the wider range or in the range of a state or even a continent, we should, like you all said, use the structure that's already been there. Like we do in our project, we use the caretakers that are there and do an addition to this and use new technologies, but we don't go another way. So we just add something new to something that is already there. And that's the point, I think. That's the right way, I think.
We are here at the Medica, and everybody is walking through the halls and see a lot of innovation, a lot of technology, all this blinking, all this digital. Will all these digital small supporters bring e-health in rural areas quicker, or as a supporter, or is it much more a change or transformation program like you mentioned, Professor Hamm?
Well, I think it's part of the solution, and the most important thing is it's just a part. So if you solely consider the technology, you won't reach anything. And you can even destroy something, because technology without guidance can really be a problem regarding the acceptance from the user and so on. But this is also a kind of, or the question is how you approach the technology, how you understand the technology. Sometimes there are, also here at Medica, there are so many solutions, and everybody promises, well, we are the killer application, and well, okay, when it comes to healthcare, killer application might be the wrong expression, but you all know what I mean. So the killer application that makes everything better, that solves every problem, but that's not the case. In my eyes, technology can just be a lever, but if there are not if there's no progress regarding the organizational structures or the organization models and the structures in the healthcare system, then the money is spent worthless.
Okay, thank you, Peter.
Mm-hmm. That's a very good question, Nick, because if you transfer the impressions of Medica with all their blinking devices into reality, it's a hard smash. I'm working with my pharmacies in 2 rural areas. The first I stated out, it's a social area, and the second one is just simple delivering medicines throughout the country. My pharmacy in Schachtauerdorf, pretty name, is servicing an area which is as large as Hamburg. And my delivery car lasts 3 years, then it's gone. And we know exactly what patients in these areas need. They need what you've said. They need a very graceful way, which accepted their needs and give them just a small additional services, and especially they need access. That's the main point. They need access. And if the access is given by a professional, then these patients are satisfied. Halligmed is a very good example for this. It has to be done by a professional. And it's our approach in Schleswig-Holstein to lower down the barriers between the healthcare professionals and to keep us integrated, just working from this patient-centered perspective to deliver something like healthcare in rural areas. I think it's the best solution. It has to be very, very, very careful.
One quick remark, and this is also for your profession, for pharmacists and also for doctors. In my eyes, it's not a threat, but it's a great chance. to reinvent your own role model, because if you discuss with doctors, with pharmacists, and so there's always the fear of these Amazons and Apples and Doc Morrises and you name it, but nobody can replace the care provider on site.
So back to the question how we should give all the patients the access to the best treatment. That's the main problem I think we talk about is pilotism, that we have all our projects in our agency or institutions and so on, but when they're at the deadline, so they run for 3 or 4 years or even in this time frame, and what is after that? So we have no structure in Germany, was said like the GBA. We have a concept that is especially for new innovative technologies, and how should they get into the basic coverage for everyone. So they stay just in this target group or just in this local group they are invented in.
Yeah, that's really right. So that I guess is one of the German history. After the pilot is before the next pilot, and I guess we are old enough to understand what happened in the different healthcare reforms. It was tons of pilots, and then came a next Ministry of Health, and we have another reform and some other ideas, and have another pilot. So you can do. And for me, I guess sometimes it's sorry for the academics, but I guess there's the industry of evaluation. So it's they are happy that they can evaluate, but from them it's now coming not some recommendations how we can plan the rollout. Peter.
Yes, maybe in addition, we thought about this in our small approach, which includes doctors, statutory health insurance, and us, and we built this project keeping in mind that it has to be transformed. There has to be a possibility that it has to be transformed into the base level of medical care. So if you build up your projects just thinking about this critical point, there's a good chance that it will work. In our case, simply, there will be a way. There is a way integrated in the project. If it's useful, the doctor can simply prescribe this ECG monitoring as a service, simply. And the insurance companies have to state out: is it useful or is it not useful? So that's a way how you can transform pilots into regular healthcare.
Lucas?
So there was a nice study last year in 2017 from the IGES Institute and the Bertelsmann Foundation, and they proved what are the factors, the main factors, 15 factors of successful new telemedicine projects. And they found out that even though you have fulfilled many of these factors and you have a success in your project and did a positive evaluation, you can't get access to the basic coverage, and it's not really clear how it could be better.
Okay, thank you. Some questions from your side? I have one question. I guess data protection is always an issue, and we discussed it last Friday on another audience, and the summary was a little bit that sick people think different about data protection. How is it when you were promoting your Hallig project? Are all these inhabitants of the Hallig positive, or have they fear that all the data are now open for some others, or how you handle with this?
It was more the interested people in this project and not the inhabitants of the remote islands that are interested in the data secure and so on, because for critical people it's always an argument on any project, on any new technology, the data security, is it granted or not? And they use it often as a block of this project and don't see it like it should run at the same time with the project in combination. So it's more like a block, but we prevented this by using our data center in Schleswig-Holstein and so on a very early point on the project, and that was really necessary.
Peter?
That's a very high-level discussion, especially in Germany. That's data protection versus health protection. All our efforts to start telemedicine, to start the EGK, also the electronic health care card in Germany, started with Lipobuy and their interactions with other pharmaceuticals, where people died from this. And I remember we are talking to the data protectors, the official ones, and asked them, it's no problem for us to scan through our prescriptions and to isolate these patients, call them and tell them, oh, be careful, don't do that on a central base. That's possible. But the clear answer of the data protectors was, no, you shouldn't do that. So that's really a conflict between data protection schemes on the one hand and providing healthcare as a protective approach. So I think there has to be a discussion, which is also mentioned by Josef Hecken, the chairman of the GBR, which stated out clearly that it's as a patient, if I want to take care in a German system, I have to admit that I lose my data rights some kind. Yeah, it's a necessity, because you need this little step behind your right to own your own data in the case of an emergency and in the case of something like critical interactions. So that's really a critical point in the German development of e-health. We are now busy in focusing on how can we overcome this old view to a more professional view. The more professional view is that we say, if we have, as a healthcare provider, we need to look at data at the complete level, at the total level. That's our profession. The patient must look at his own data. That's okay. He must know about his conditions. But if he is able to reduce the data set on its own, there are risks produced which are not acceptable for us as healthcare professionals. So that's a conflict. And the solution is pretty simple. You have to block interprofessional communication and keep this communication totally secret. That's a communication which has to happen between professionals to solve a problem which a patient has. That's absolutely necessary. And if you do this, the patient always has the right to look at these data, but not to interfere with this data in this kind that you can say, oh no, I don't know, I don't want you to know this or this or this. That's on some reasons that may be very personal, but they have nothing to do with the medical profession's objective to take care for the patient.
Steffen, in Bavaria, the Bavarian is much more pragmatic, especially in your region where you are, so in this rural area, or is sometimes the data protection discussion only a discussion for the capitals or for the Berlins?
No, not really. We also have this discussion, but a friend of mine who's running a startup for biomedical data always says, I think more people have died from data protection in the German system than it has saved them. But in my eyes, the discussion is always like yes or no data protection. But that's not the case. In my eyes, it's rather where do we access, or at which point happens the data protection. The German approach is we want to anticipate every hypothetical mistake that could happen, and then we want to prevent everything that could lead to these mistakes. In other countries, for example, if you look to Denmark. They have a more liberal approach. Of course, if something is happening like data misuse, then there are sanctions as well. But in a first step, there's a more liberal approach, and this opens up more possibilities to make use of the data. And but of course, we also have these discussions in our projects, and the advice that we are giving is especially to startups and founders and so on. Just as the business model has to be clear in a first step, so also a basic concept of data protection has to be clear. But because this is in my eyes very important not to run into this pilotism again. So if there is no idea of any kind of business model, then leave it.
Okay. I just look at the watch and the time is flying by, so let's come to the final round. Some questions from your side, then I have one final question to each of the participants here on the panel. Lukas, what will be next after the Halleck for you?
Yeah, so we already think about new projects and how should this Halleck project go further and go on, and maybe for the whole space of Schleswig-Holstein or so on, or other cases that you can use maybe in jails or something. All these cases where there's no doctor reachable immediately, and there I think are many cases, or even on ships on the sea, there is really need of help for emergency cases.
Okay. Peter, you have access to some of the politicians. What you will tell them here from this audience and from what we shared was Steffen Hamm was mentioning what is the issue, not a technical issue, so how we can go forward. You sometimes can write laws and can build up the highway to Ihals or the highway to...
Well, thank you. I've learned from this panel a lot. I've learned that the integrated approach is the right way. I've learned that we have to think about our data protection schemes, and we have to keep care that we don't do pilots anymore. That's a really hard message, a very good message. And the next steps will be to deliver this into the political process which is running right now around the German e-health legislation. We have a minister which is very proud to be very digital, but we have to teach him maybe some lessons. It's not a good idea to not remember all the things that already exist and just to put something blinking on top of this. It's a good idea to keep all the partitions on one desk and to discuss how can we deliver e-health in a substantial way. That's the message from me, or the lessons learned from this session.
Okay, thank you. Boris, with your experience in Kenya, and following this discussion, what you would like to recommend to the Germans how they can come forward? Sometimes we have the impression that, coming up from other platform, but that the Kenyans are much more pragmatic and go forward.
Yeah, I think I can say that there's definitely a pragmatism to the approach, but this is always like that. If the pressure, the need is so high, people move faster because you're just on a completely different level of healthcare gap. So therefore, we appreciate the environment actually in Kenya, which is very digitally savvy. So the good thing, for example, if you meet a community pharmacist, he's probably pretty good on using a smartphone. And that's what is actually a good entry point, because he will know how to operate some key digital devices, and he will know how to, if he gets the means and the tools to connect into a healthcare system, or local at least healthcare system. So for us, that speaks to your first question also, what's next? So establishing these 5 units and integrating them in the local healthcare system. And then the question, can a solution suite be scaled to other community pharmacies? to improve their services. So bottom line, the future in countries like that, for us, for our perspective, is shifting from just dispensing tablets to actual pharmaceutical patient care. So the pharmacist takes the intermediate role, like you said before, right? Between the original one and maybe the doctor. And I think it could be possible. And in that countries where there's a huge gap of healthcare professional, it's a perfect situation actually. Okay.
Now, final question to the professor. What you are teaching your students, how they can help us to implement the ideas, how came out of the pilot phase?
Well, with an eye on the watch and an ear on the music, I keep it simple.
Yeah.
And this is actually what I say my students. Keep it short and simple, as the marketing slogan is very well known. Because we sometimes, I think, have made the experience that we tried to build up a super comprehensive project that is supposed to solve everything. But sometimes, as you mentioned, in Kenya and in other countries, the small steps bring us bring us much further. So this is what I also tell my students: be courageous enough and be an entrepreneur. And don't see the hurdles, see the chances that the healthcare system and the healthcare market brings.
Thank you. Thank you very much for all your participation. It was very interesting. I guess very nice comments. Sometimes was different than I expected. I guess it will be interesting when we will meet here in the same stage in 5 years, what happened, and perhaps look proud backwards or look what we could or what we then delivered. The other thing, I wish you a nice trip back. Drive carefully. We need you for the digital health implementation. And thank you for your participation.